Hello, this is Olga Libova, and today we're going to talk about hormones, drugs that affect endocrine, endocrine system, and more specifically, drugs for pituitary, thyroid, adrenal disorders, and calcium metabolism. I'm going to share my screen and put it on the slideshow, and we are going to start. So endocrine system consists of glands that secrete hormones. And the function of endocrine system is to maintain homeostasis in the body using hormones as chemical messengers. In our lecture on diabetes, we also talked about the differences between endocrine systems, the ones that communicates with other organs via hormones that it sends through blood, and exocrine system, which is a direct communication when, for example, pancreas produces enzymes that affect GI tract. So today is endocrine system, and our main word in endocrine system is an enzyme. So enzyme is something that the endocrine system produces, and then it has effect on the target organs. The release of the hormones is commonly controlled by negative feedback, and that's a very important mechanism that we are going to discuss in a second. But let's first talk about some what organs are in endocrine system. So in your brain, you have a pineal gland, which we will not talk about today. But we also have two organs that used to have very similar name. One was called hypothalamus, and another was called hypophysis. And as you can imagine, that was very, very confusing because they both actually mean the same thing. Hypo means low or under something. So hypothalamus means under the chamber, and hypophysis also means that it is under the structure because it was under the brain. So thankfully, in the United States, because United States like to do everything more simple, they started calling hypophysis a pituitary gland. So that's why you kind of have a fancy name, hypothalamus, and a non-fancy name, non-Latin name, pituitary gland. But if you read the literature that comes from outside of the United States, you can still see the word, the use of word hypophysis, and you can have adrenal hypophysis, which is the anterior pituitary, because it's actually the true adrenal gland, and posterior pituitary, which is actually theoretically a part of hypothalamus, is called neurohypophysis. And just to make you a little bit more confused, there is also hippocampus, which is a part of the brain, but it is actually not hypo as under, it's hippo as a horse. Okay, so again, the brain has three different weird words, but the one that we are dealing with is hypothalamus, which is a master conductor of the whole endocrine system. Okay, hypothalamus, master conductor of the endocrine system. Then we have pituitary gland, which is the second conductor. Maybe hypothalamus is a composer and pituitary gland is more a conductor, we can call it that way. And then anterior pituitary actually sends directions to the individual glands as well as some other organs. And the examples of glands that are directed by the hypothalamus and pituitary gland are the thyroid gland, the adrenal glands, the ovaries in women, and the testes in men. And these organs after they're stimulated by the hormones that are produced by the anterior pituitary, they in turn produce their own hormones. Okay, kind of a little convoluted. And the mechanism that is in charge of all this complicated system is a negative feedback or positive feedback. So most common pathway is a negative feedback, which basically makes sure that the endocrine organs do not go into overdrive, that they do not produce more and more, or less and less. So how the negative feedback works, and the slide has an example of the parathyroid hormone, but I actually like the example of thyroid hormone. So the thyroid gland itself produces hormone T4 and a little bit of T3. So, but we mostly know about T4 because this is a more stable hormone, has longer half-life, and when T4 reaches target organs, it actually gets converted into T3 inside the target organs. And there is a hormone that stimulates the thyroid to produce a T4. And that hormone is called TSH, or thyroid stimulating hormone, because it stimulates thyroid to produce T4. And TSH, as you can guess, is produced by anterior pituitary. And anterior pituitary produces TSH because in turn it gets stimulated by the hypothalamus. The hypothalamus produces thyroidine release, the thyrotropin releasing hormone, and thyrotropin is another name for TSH. So anterior pituitary produces thyrotropin, which is TSH, which in turn stimulates thyroid gland to produce T4 and T3. Okay, so what happens if we have too much of T4 in the blood is that the hypothalamus senses that there is too much T4, and it actually decreases the production of TRH. That's why it's negative, right? There is a lot of T4, so there will be less TRH, which in turn will cause anterior pituitary to release less TSH. And because it releases less TSH, the thyroid gland will slow down and produce less T4, and the hypothalamus will feel that it's producing less T4 and decrease and say, oh, okay, now I can go back to normal and increase the production of TRH. If we get very little T4, right, And hypothalamus will understand that, oh, we're producing very little T4, it will increase the production of TRH. So these are the example of negative feedback. And so it just happens that it is the easiest for us is to measure the level of TSH. And so what do you think is happening if TSH is elevated? Well, most likely there is not enough T4 produced by the thyroid gland. And TSH is just trying to kick thyroid's butt to produce more T4. So when we have elevated TSH, most commonly, it means that we have primary hypothyroidism. Okay, so the thyroid gland itself, that's why it's primary, because the problem is with the thyroid gland itself, is not producing enough hormone. And that's why TSH has to get elevated to stimulate it. Okay, and that is caused Hashimoto's thyroiditis. It is an autoimmune disease, and it's a result of destruction of glands in the thyroid of T4 producing cells in a thyroid gland. So that's kind of similar to type 1 diabetes, right? In type 1 diabetes, the pancreatic cells got destroyed by the antibodies, right? It's also an autoimmune disease. And so your pancreas cannot produce enough insulin. But unfortunately, there is no such easy way because pancreas is not regulated by the pituitary and hypothalamus. Okay, so this is an example of primary thyroid insufficiency. On the other hand, we can have a secondary thyroid insufficiency, and that happens when somebody is completely malnourished. For example, in the case of anorexia nervosa, when the person is starving and the whole body is going into hibernation. And so hypothalamus is basically saying, I'm not going to do anything other than bare minimum because we don't have resources. We are cutting corners everywhere. We are in survival mode. And so in that case, everything will be low. The TRH will be low, the TSH will be low, and the T4 will be low, right? But that's very unusual. You really need to be mean to your body to put it in that survival mode. Sometimes we have a positive feedback, and that happens, we'll talk about it in the reproductive endocrinology when we talk about ovulation. And in the case of ovulation, the follicular stimulating hormone, this FSH hormone, is stimulating the ovaries to produce more estrogen. And at some point, there is so much estrogen that the body says, oh, I guess I need to ovulate. And actually, instead of suppressing FSH as it would do if it was a negative feedback and say, hey, stop producing that much estrogen, it actually has a big release of another hormone called LH that stimulates even more estrogen production, but even more interestingly causes ovulation, the release of the egg from the ovaries. Okay, so this is just a big overview for you of like what can be happening in the endocrine system. It is really cool. It is very logical. It is, I think, the most analytical system in the body. But for our purposes, there are two things that we need to remember. One is negative feedback, which means the less target hormone, like for example, as an example in your in this slide, the less parathyroid hormone is released by the parathyroid gland, the more the body will stimulate parathyroid gland to try to make more parathyroid hormone. Okay? And that happens most of the time. That negative feedback happens when we have the primary insufficiency, when it is the gland itself that is not working properly. Now, when we have a secondary insufficiency, meaning that the problem with adrenal gland, the problem is with the pituitary gland itself, or maybe even with the hypothalamus, then we don't have the same mechanism. Okay, we'll come back to it. I know it's confusing, but we will come back to it. Okay. So as I said, a hypothalamus and pituitary gland control other glands. Hypothalamus secretes the releasing hormone. Again, these hormones here released by hypothalamus called releasing hormone. It makes the pituitary release the stimulating hormone. And posterior pituitary is kind of a little bit different. See, posterior pituitary releases the hormones that do not stimulate other organ to release other hormones. It's just stimulate the uterus with oxytocin and stimulate kidneys with antidiuretic hormone. So what we need to remember is that there are two hormones released by the posterior pituitary, and that's ADH, antidiuretic hormone, and oxytocin, the contractions of the uterus hormone. So that's released by posterior pituitary. And, you know, it's like, I don't have any good way of remembering that. The way I remember is when we induce somebody, we want somebody to have contractions, we give them Pitocin, which is the equivalent of the oxytocin, but we sometimes jokingly call it vitamin P. So posterior starts with P as well. So that's how I remember that posterior lobe releases our vitamin P, which is Pitocin, or which is brand name for oxytocin. And because I think of, and when you have a lot of contractions, the water breaks, so I also connect antidiuretic hormone. I love that they use this great name for antidiuretic hormone. You know exactly what it is doing. It is prevents the body from diuresing or losing fluid, right? So antidiuretic, great name. There is another name for that hormone, which is vasopressor, because if you are retaining fluids, that will increase your blood pressure. Okay, and that's why it's called vasopressor as well. So ADH and oxytocin, two hormones that are produced by posterior pituitary gland, and they go straight to target organs. Another weird one is, well, it's not really a weird one. Okay, forget it. So MSH, melatonocyte stimulating hormone, is a hormone that we will not be talking much about. It just goes to the skin cells, and in skin cells, it stimulates the melanocytes to produce melanin, which is responsible for the color of our skin. And you might remember that if you do not have melanocytes, or there is a problem with MSH, the person will have a condition called albinism. The person will be an albino. So in this case, we don't have really an organ. Well, skin is kind of an organ. So that's why I'm saying that it's a little bit weird. Melanin stimulating hormone stimulates melanocytes. Just a word of caution, as a nursing student, I always got confused between melanin and melatonin, right? So melanin is the skin color hormone. Melatonin is the sleep cycle hormone. Melatonin is what tells us that it's time to go to bed, and it is related to sun exposure. Okay, and then we have 6 other hormones that we will be discussing. Well, actually, no, one more weird one, the prolactin. The prolactin goes to the breast tissue and makes breast release milk, which is not really a hormone. So yes, again, there is another one that is weird, which is prolactin, also produced by anterior pituitary. Very interesting, a little piece of trivia. You don't have to remember that, it's just very interesting. So prolactin is actually antidote to dopamine, okay? And that's why when the woman is breastfeeding, she tends to be very mellow, which is good, but she also tends to not enjoy sex as much and not have great orgasm, because prolactin significantly dampens the reward and excitement effect of dopamine. Okay. Okay, so the really interesting hormones are FSH and LH, which we will not be talking about today. These are reproductive hormones. They are discussed in the reproductive lecture. Growth hormone acts on the peripheral tissue, and the lack of growth hormone is responsible for dwarfism in some people, and excess of growth hormone is responsible for the condition called acromegaly. And then finally, 2 hormones that we really will be paying a lot of attention to today is the TSH hormone that works on a thyroid gland, and ACTH, adrenocorticotropic hormone. So this is a hormone that stimulates adrenal gland to release adrenocorticosteroids. Okay, that was long. So we talked about this. These are some examples of the conditions that we will be talking about today and at the next class. So adrenal cortex, sometimes you will see the word HPA axis, which stands for hypothalamus pituitary adrenal. So it's just the abbreviation that sometimes you will see in literature. So adrenal cortex, again, our hormones are corticosteroids And if you have hypersecretion, you have Cushing syndrome, and hyposecretion is Addison disease as examples. We'll talk more about it. With gonads, we have ovaries that make estrogen and progesterone, and testes that make testosterone. We have pancreas that produces insulin that we already talked about. We have parathyroid gland, which is right next to thyroid gland. And parathyroid gland is responsible for producing parathyroid hormone, which is in charge of calcium balance in the body. Then we have, again, our pituitary that produces antidiuretic hormone, growth hormone, oxytocin, and all these other stimulating hormones that work on thyroid and adrenals. Okay. So the first condition we will talk about is called diabetes insipidus, as opposed to diabetes mellitus. Remember, diabetes mellitus is sweet water. This is fair water, very transparent water. And antidiuretic hormone is and antidiuretic hormone also is in charge of keeping the blood pressure up. When the person has a genetic variation that causes deficiency in ADH, the person gets diabetes insipidus. And that is a condition that can be treated with a desmopressin or DDAVP. And this is our prototype, our first prototype drug. Again, it is a complete synthetic analog of human ADH. It is interestingly also used for management of bleeding patients with hemophilia, but to tell the truth, I don't even remember how it works. I guess we'll find out. And your biggest adverse effect is water intoxication if it significantly interferes with the loss of the water. And so what happens with water intoxication is hyponatremia, right? There is not enough, like the sodium gets too diluted and the person can have seizures and even die from it. Okay, so we don't want that. Okay, my favorite use of this drug is for nocturia, when kids wet the bed during the night. And I had really amazing results. There was my friend's son who was 11 years old. And, you know, when you're 11 years old, it's pretty distressing for you and your family if you're still wetting the bed. And they tried all kinds of things that like shaming him and putting bedwet alarm, and nothing worked. And he had a nasal spray of desmopressin and it worked like charm. So that was really good. That's how it works. It produces an increase in clotting factor 8 and in von Willebrand factor, and is indicated for the management of bleeding in patients of hemophilia A and von Willebrand disease. And here is my favorite use for bedwetting, and that also can be used for polyuria in adults. I'm guessing maybe somebody with benign prostate hypertrophy. If it is used IV, fluids must be restricted and carefully monitored to prevent serious water intoxication. And again, because it dilutes sodium, you need to make sure that sodium is normal. I don't know if any of you remember, a long time ago, some stupid radio host did a challenge of how much water the listeners can drink. And I believe there was a woman who died of water intoxication just from drinking too much water. Okay. Okay, so you definitely don't want to give it to people with chronic kidney disease. Caution with patients who already have hyponatremia and hypertension. And especially young children and older adults are always more prone to any complications. And doesn't have too many drug-drug interactions. But and this is definitely the case where we want to treat it with osmotic diuretics. We want something that will just collect that water. Role of the nurse: make sure that your electrolytes are balanced, make sure that you check body weight and urine, and look for headaches and changes in mental status. Okay, so I think there are a couple of questions of it on both the quiz and the exam. Okay, thyroid gland. Thyroid gland secretes mostly T4, which is thyroxine, and some of triiodothyronine, T3. And there are also another interesting fact about thyroid gland that people tend to forget is that different cells in thyroid gland release calcitonin, which has the opposite effect to parathyroid hormone, okay? And we will talk about it at the end of this lecture when we talk about calcium metabolism. But again, remember that thyroid gland is not only responsible for release of thyroid hormones, but also calcitonin, which is a calcium balance hormone. It also can be elevated in cancers. Very interesting markers. Sometimes you will see in your patient that the doctor will be measuring calcitonin for other reasons. Okay, iodine is essential for synthesis of T4 and T3. You might have noticed that most salt that is sold in the normal stores is fortified with iodine, and that was one of the most effective public health measure to prevent the condition called cretinism. So cretinism is actually not a bad word, it's just a medical diagnosis. It is mental retardation that is caused by the lack of thyroid hormone. So one of the problems that I see these days is that there are these fancy salts like pink salt and iodine salt, and these fancy salts are, not iodine, I'm sorry, Himalayan salt, pink salt, Himalayan salt, sea salt, and they are not fortified with iodine. So we are actually more concerned about iodine deficiency in patients, which we didn't have a problem with for years and years and years. So I often, and because my patients in my private practice are mostly kind of well off and often use these more fancy products, I'm actually more concerned about them having iodine deficiency than people who buy regular Morton salt. So very recommend that you use salt that is fortified with iodine. We already talked about negative feedback loop when there is low levels of T4 in the blood. The hypothalamus releases more TRH, which in turn makes pituitary gland release more TSH. So if somebody has hypothyroidism, primary hypothyroidism, their TSH will be elevated, but T4 will be decreased. And the other way around. If we have too much of thyroxine, then we will have a decreased TSH. And this is a picture that talks about what we just described, and the work of endocrine cells. So here is your hypothalamus and anterior pituitary and your negative feedback loop. So hypothyroidism in adults used to be called myxedema. And early symptoms include general weakness, muscle cramps, dry skin, slurred speech, bradycardia, weight gain, decreased sense of taste and smell, and intolerance of cold environments. They feel cold. So interestingly enough, a lot of my perimenopausal patients come to me saying, I'm sure I have hypothyroidism. You know, I'm gaining weight. I am cold all the time, and then I get a hot flash. But most of the time, I feel that I'm much more cold. My skin feels dry. So the symptoms of menopause, which is the lack or the drop in the estrogen and progesterone and testosterone, often present very similarly to hypothyroidism. And as we discussed, we have elevated TSH because the body is trying to compensate, but decreased T3 and T4. Most of the time, we're only measuring free T4. Now, if we have the other issue, we have too much of the thyroid hormone, that is hyperthyroidism, and it causes increased body metabolism, which will cause tachycardia and weight loss and elevated blood temperature and anxiety. And these can be confused with generalized anxiety disorder. So I actually had a patient that came complaining that she cannot sleep, she is not interested in eating, and but she thinks that she is eating normally because she makes herself eat, but she's still losing weight, and she thinks that she's so stressed at work, but actually she was stressed at work, but she also had hyperthyroidism. Okay, so the most common cause of hypothyroidism is it being a primary hypothyroidism, meaning at the level of the thyroid gland. And it's caused by an autoimmune thyroiditis called Hashimoto's disease. One thing that you need to remember about autoimmune diseases is that if somebody has one autoimmune disease or has autoimmune disease in the family, they are more likely to have other autoimmune diseases. And that includes Hashimoto's, thyroiditis, type 1 diabetes, celiac disease, lupus, and so on and so forth. So elevated TSH with decreased T3 and T4, and the treatment is most commonly, like 95% of patients you will see on synthetic T4, which is levothyroxine. Because remember, T4 gets converted into T3 in the target tissues. And because T3 has so much shorter half-life, it actually doesn't make sense to supplement with T3. Having said that, there are people who do not get better on levothyroxine, and there are, not commonly, but once in a while, we see patients who is either on Armour, which is the natural porcine-based T3, T4 combination, meaning that it was made from the thyroid gland of pigs. That's what porcine means. And once in a while, you see people who are on both separate supplementation of synthetic T4, which is levothyroxine, or Synthroid, which we mostly see, but also the T3 supplementation as well. But you don't have to remember any of what I just said. For the test, you only need to know levothyroxine, which is artificial synthetic equivalent of T4. As I said, it's a drug of choice. And as you can imagine, the adverse effects will be symptoms of hyperthyroidism, which is palpitations, dysrhythmias, anxiety, insomnia, weight loss, heat intolerance, as well as menstrual irregularities and osteoporosis. So, Synthroid is the brand name of levothyroxine, and it is one of rare cases when many patients do notice significant difference between the brand preparation, which is Synthroid, and generic preparations of levothyroid. So you will sometimes see patients that will bring their own Synthroid because the hospital only has generic, and say, no, I'm not taking the generic because I have very sensitive I have very sensitive system. I need to have 37.5 micrograms of Synthroid on Monday, Wednesday, Friday, and we do 50 on the other days because, again, I'm very reactive to it. We check the level of, we check the effectiveness of our medication by checking TSH every 4 to 6 weeks, okay? Again, high TSH means that we still don't have enough. Low TSH means that we are giving too much, okay? So again, it takes about 6 weeks for the body to find the equilibrium. So typically, we will not check the level of TSH earlier than maybe 4, but generally 6 weeks after the patient starts treatment or adjusts the dose. Definitely any big changes in the body, like pregnancy, typically will cause adjustment. In pregnancy, we actually do it every 4 weeks. For some patients, they really need to be adjusted when you start medications that, like corticosteroids. I mean, any big changes in the body's function, we need to recheck the TSH levels. We want patients to take medication in the morning on empty stomach because it works best on empty stomach. And we absolutely have lots of data on safety of using levothyroxine in pregnancy. And our adverse effects are just symptoms of hyperthyroidism. I have patients who come and say, oh, I know my TSH was normal, but I'm gaining weight. I think I just need a thyroid hormone. Maybe it will help me to lose weight. It is actually contraindicated as a weight loss medication because of the potential of causing hyperthyroidism related complications such as AFib, atrial fibrillation. Interestingly enough, completely off label, but it sometimes is used for patients with depression. Hypothyroidism can also mimic the symptoms of depression, and that's one of the things that we always check on patients before we start them on antidepressants when we're doing the depression evaluation. Make sure that they don't have hypothyroidism. And if somebody has depression that is resistant to treatment, as a third or fourth option, I have seen physicians, psychiatrists giving people very small doses of levothyroxine. But again, it's not an FDA indication. Contraindication is adrenal insufficiency, cardiovascular diseases, and interferes with diabetic medications. Okay. The dietary fiber decrease the absorption of levothyroxine from the GI tract. Again, that's why we want to give it an empty stomach, and we want to avoid calcium and iron supplementation for 4 hours. And levothyroxine may increase the effect of warfarin, but again, what doesn't interfere with warfarin? Okay, and that's another interesting thing. Well, we'll talk about actually about it when we talk about hyperthyroidism, the use of beta blockers for hyperthyroidism. Okay, so role of the nurse is make sure the patient is not tachycardic, does have a regular heartbeat, hypertension, nervousness, all these hyperthyroidism symptoms. Okay, now hyperthyroidism. The most common cause is Graves' disease, which is really confusing because it's also, an autoimmune condition. But it's different antibodies, and these antibodies, instead of destroying the cells that produce thyroid hormone, they actually increase the production of thyroid hormone. Very weird. And we can give the class of medication called thioamides, which is PTU or methimazole. Or sometimes if the cells of the thyroid do absorb iodine, they can give radioactive iodine to kill overactive thyroid cells. And that's very interesting. They basically first need to do a study to see if the cells will even absorb iodine. And if they do, that's one of the possible treatments. But the problem is they can overkill, they can overshoot and put the patient into hypothyroidism. Okay, and so we have the prototype drug is PTU, and it interferes with synthesis of T3 and T4 in thyroid gland, but also prevents conversion of T4 to T3 in target tissues. And if we suppress the function of thyroid gland with this agent, we will have symptoms of hypothyroidism, as well as we have transient leukopenia and agranulocytosis as possible adverse effects. Okay, so, interesting. So here's they use metimazole as a prototype drug. I thought that it was PTU before. Well, I guess they changed one thing, but didn't change another thing. I don't see PTU work used as much anymore. I definitely see metimazole used more. So it is administered to patients with hypothyroidism. It interferes with synthesis of T3 and T4. And I actually do see it used in pregnancy because we don't have better options, but it's definitely not without problems. Some patients have problems with their blood cells, again, thrombocytopenia, aplastic anemia, granulocytosis, and it interferes with the iodine. So sometimes they do metimazole first, and then they do the treatment with radioactive iodine, which is I-131. And it interferes with action of warfarin. It has effect on liver and increase the levels of liver enzymes. What is interesting is when I had a patient that I mentioned that ended up having hyperthyroidism, but also had anxiety as well. One of the medication that, because it takes metimazole some time to become effective, takes 4 to 6 weeks, but in the beginning, the endocrinologist actually gave her a beta blocker that helped her with anxiety and heart palpitations and tachycardia. So it's, again, a symptomatic treatment, but not the treatment of the problem. Okay. So very important, it is on the test. If we are doing the treatment with radioactive iodine, the person needs to avoid children and pregnant women for 1 week after the administration of radioactive iodine, and limit close physical contact with others for a few days, because basically this person is radioactive. We do need to monitor for symptoms of hypothyroidism, assess for signs of jaundice. So that's very important. Anytime you are dealing with a medication that has a hepatotoxic effect, on the test, you might be asked about yellowishness of the skin, right? So if you have a patient who is on antithyroid medication, and the question is which finding the nurse should report to physician immediately, the answer would be definitely heart palpitations, right? Heart palpitations are always the answer, but if you have an option of the patient saying, my eyes seems to be more yellow, or I think my skin is changing color to yellow, this definitely would be something that the nurse would need to report to the provider. Okay, we are done with thyroid, and now we are moving to adrenal cortex. So adrenal gland, here is our adrenal gland, and it has a medulla, which is the inside portion, and you kind of can remember it by the word medium, like something that in the middle. So medulla is inside, just like medulla in the kidneys. We have medulla of the adrenals, and cortex is on the outside, just like in your brain. The brain cortex is that outside layer. And in the adrenal gland, it is the medulla, the inside layer, that produces your catecholamines, the epinephrine and norepinephrine, right? Your neurotransmitters. So neurotransmitters are made inside in the medulla. The cortex is more or less in charge of the pleasures of life, and that's how Dr. Boyev, I think, talks about it. That's how they remembered it in medical school. Your cortex is affected by salt, sugar, and sex, right? Like three big things that make you produce epinephrine. So the outer layer is mineral corticoids, and that's aldosterone, right? And they call mineral because they are in charge of regulating your minerals, including potassium and sodium chloride is salt. So aldosterone, right? Remember the hormone aldosterone is in charge of salt and water retention, right? So salt, then you have glucocorticoids, and that's that's sugar. And finally, the next level of the cortex produces androgens, which is estrogen and testosterone, which is sex, right? So you have salt, sugar, and sex are produced in the cortex, and medulla gives us epinephrine. So we get really excited for salt, sugar, and sex. Okay, so glucocorticoids mobilize body for long-term stress, influence carbohydrate, lipid, and protein metabolism in most cells. Okay, then you have mineralocorticoids, which is mostly aldosterone, and finally gonadocorticoids, which is mostly androgens because women have ovaries that produce majority of estrogen and progesterone. Okay, control of glucocorticoids. So hypothalamus releases corticotropin releasing factor of CRF, which causes adrenocorticotropic hormone, or ACTH, to be secreted by pituitary. And then adrenal cortex releases glucocorticoids, or glucocorticosteroids. And this is our HPA axis. Remember, I mentioned the word for you, HPA, hypothalamus, pituitary, adrenal. So when cortisol level rises, negative feedback mechanism shuts off further release of glucocorticoids, just like we discussed negative feedback in thyroid gland. Okay, here is the picture of negative feedback, how it will, the increase of glucocorticoids in the blood will give order to both pituitary and hypothalamus to shut up. You also can see here on top that, just a completely side note, that circadian rhythm and stress have effect on hypothalamus. And remember, the hypothalamus is in charge of everything in the body. So it makes perfect sense that when people travel, right, and so their circadian rhythm is disturbed, or when they're stressed, that will interfere with all the hormones, with HPA axis, but also with the menstrual cycle in women, right? Okay, so we have two mechanisms of insufficiency of adrenocortical hormones. Most common one, and that's the one that JFK had, like our president, he had Addison's disease. And so he had problems with adrenal glands themselves. No matter how much ACTH was produced by the anterior pituitary, his adrenals could not produce enough corticoids, both glucocorticoids and mineral corticoids. So in the case of primary insufficiency, if you inject the patient with the analog of ACTH, nothing happens, because it is the adrenals themselves that are a problem, not a lack of ACTH. And that's most common situation. There are also situations when we have secondary insufficiency. And that's on the level of hypothalamus or pituitary, right? When not enough ACTH is produced. And that most of the time, it's rarely a problem on its own, but most of the time, it is the result of the patient getting steroids, okay? And if the patient receives steroids for a significant period of time, right? You have a negative feedback, there is too many steroids, so the body will decrease the production of both CRF and ACTH. And then if you abruptly stop the steroids, it will take time for the hypothalamus and anterior pituitary to understand that things change. They don't work very fast. So they will keep producing lower amounts of ACTH. And as a result, the person will have the same symptoms as primary insufficiency, right? But if we give this person cosintropin, which is the analog of ACTH, that person will have a reaction and will increase the cortisol level. So that's why it's absolutely essential that corticosteroids are discontinued gradually to prevent secondary insufficiency. Okay, so we talked that Addison disease is a primary adrenocortical insufficiency, deficiency both in corticosteroids and mineral corticoids, so both gluco and mineral. And they have nausea, vomiting, lethargy, confusion, and coma. And again, you will have low cortisol with high ACTH. We have as we discussed in a lecture about inflammation, we use corticosteroids often for treatment of inflammation. We use it for autoimmune diseases, and many other. It's one of the most commonly used medications. So you have short acting, which is hydrocortisone, intermediate acting, which is prednisone, and long acting, which is betamethasone and dexamethasone. And the risks are hyperglycemia, right? That's why they called glucocorticoids. Peptic ulcer disease, if used with NSAIDs or aspirin, that by themselves can cause peptic ulcer disease. And for some reason, with hydrocortisone, there is a decreased response to vaccines and toxoids. I actually think that all corticosteroids have decreased response. I cannot tell you 100%, but I believe that all of them. Okay, and now we have the opposite problem, which is Cushing syndrome, which is high levels of corticosteroids in the body over a prolonged period. And you do need to know the signs of symptoms. And the redistribution of fat, the moon face and buffalo hump, would be your clues on the test a lot of times. Most of the time when we talk about Cushing syndrome, we talk about the symptoms that are due to, actually, here it is. Here is what I'm trying to say. So most of the time it is due to exogenous factors, meaning that the person is taking high doses of corticosteroids and develops the symptoms and may develop the symptoms of overdose. It is most common reason for Cushing syndrome. Okay, so two problems with steroids. When the person is taking steroids, they are getting all this adrenal atrophy, osteoporosis, hypertension. Remember adrenal atrophy, right? Because of the negative feedback, the body is like, oh, I don't need to make any of these hormones. So you have a drop in ACTH and the adrenals basically go to sleep. You also can have Cushing disease, and that would be when the pituitary gland actually has a tumor that produces too much of ACTH, which in turn stimulates adrenal glands to make more cortisol. So in this case, you will have a secondary adrenergic syndrome, is a Cushing disease. You also can have the primary adrenal gland disease, which is the adrenal gland itself has a tumor that produces corticosteroids. And I'm just remembering, I think there was a Dr. House episode about this guy who was incarcerated, and he had multiple cases of completely uncontrollable rage. And he was actually on the death row. And Dr. House actually found out that he had an adrenal adenoma that made, or maybe it was a pituitary gland. So either or. So there was some adenoma, some gland, either pituitary or adrenal adenoma, that was producing this like bursts of huge amount of adrenal hormones, and that caused his rages. And so he actually had a surgery, and I think they saved him from the death row. Okay, so what you need to remember from Cushing syndrome is that most likely it is a syndrome from the patient taking steroids, and you have moon phase, buffalo hump, very important mood and personality changes. Huge deal, especially for older patients, can have really like psychosis from steroids. Increased risk of infection, delayed wound healing, osteoporosis, hypertension. And we use, so if the Cushing syndrome is due to corticosteroid drugs, they are decreased or discontinued, but there are also these medications that you don't need to remember that can be used if it is a Cushing disease. And oh, here is a great table. Please, please, please know this table. This is adverse effect of long-term corticosteroid therapy, which basically very similar to the Cushing syndrome. Okay, ACTH is mostly used to distinguish the primary adrenal insufficiency from the secondary adrenal insufficiency. And we talked about it at a previous slide. With a primary adrenal insufficiency, administration of ACTH will not cause a rise in cortisol, which is in secondary adrenal insufficiency. It will cause the rise of adrenal cortisol. And so the medication for adrenal insufficiency is corticosteroids. And let's just go over it. We already talked about it. So let's jump to calcium and vitamin D in homeostasis of the body. So calcium and vitamin D are critical for the function of nervous, muscular, and cardiovascular system. You need adequate level to prevent muscle spasm, transmit nerve impulses, and provide stability and movement. It's also important for blood coagulation. Calcium is one of the we use calcium channel blockers when we are trying to decrease the contractility of the heart. To maintain homeostasis, we have the parathyroid hormone PTH, calcitonin, and vitamin D. So this is a picture of the parathyroid hormone that again uses the negative feedback. If there is low level of calcium in the bloodstream, we get release of parathyroid hormone, which actually breaks down the bones to release calcium. Also increases calcium. Thyroid gland produces calcitonin, and it builds up bone. So calcitonin is a hormone that actually puts the calcium from the blood into the bone for storage. Remember, kind of similar to how insulin puts the glucose for storage. Calcitonin also decreases absorption of calcium in small intestines, and calcitonin is released when as we said, PTH accelerates bone resorption, so increases calcium in blood, and calcitonin removes calcium from blood, and so they influence together bones, kidneys, and gastrointestinal tract. Vitamin D is something that plays important role in calcium balance. Whilst you have cholesterol in your diet, and it aids absorption of calcium. So the inactive form of vitamin K, which is cholecalciferol, is metabolized in kidneys into active form of vitamin K. So patients with extensive kidney disease might not be able to might have calcium and vitamin D deficiency. And here is a picture again of vitamin D activation induction. And I don't know what's happening with my computer. I'm sorry, let's go back. Okay, here we are. So here is your recommendation for calcium. You need about 1,000 milligrams of calcium a day if somebody is pregnant. Children need 1,200 to 1,500 milligrams a day, and this is your normal. So we can have too much calcium, which is hypercalcemia, which will cause low muscle tone and interferes with nerve conduction. Or we can have too low calcium, which is hypocalcemia, which will cause muscle spasms and hyperphosis of hypocalcemia. I am very concerned about about my vegan patients. They are not getting enough calcium. They are saying that when they drink soy or oat milk, they milk. It's not, it doesn't provide ROK, but all other dark green leafy vegetables are high in oxalates, and that interferes with absorption. People also use sunscreen a lot, and so they have a lack of vitamin D. People with malabsorptive disorders, as celiac disease, have low levels, and people who are on glucocorticoids, anticonvulsants, and anticoagulants. Our prodrug, our prototype medication is calcium salts. And if you give calcium salts, it can cause hypercalcemia. For mild chronic horribly metabolized, horribly absorbed, I definitely prefer calcium citrate. Calcium carbonate is a common anti-acid, and it is so poorly absorbed that you just cannot over treat yourself with Tums, because they're calcium carbonate and they just come out. So it is important that if you do calcium preparations, find calcium citrate, and a lot of times it comes together with vitamin D. Calcium also interferes with iron, and you should not be taking calcium and iron at the same time. Also, calcium can cause all kinds of interactions with different medications. So again, try to not take your medications with milk unless you're specifically told. Okay, and again, severe hypo and hypercalcemia are both pretty bad. It is interesting that calcium supplementation actually does not significantly increase the risk of kidney stones, although many of them are made from calcium. And zinc-rich food, as well as iron, decrease absorption of calcium. Okay, yes, I think this lecture was too long. I don't know, I kind of got tired at some point, but I hope you survived, and I'll see you in class. Thank you.